This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Neurosurgical Review, published in 2026, titled Voxel-based Evaluation of Hemorrhage Risk in Brain Biopsies.
This is a timely topic, Ilara. We often talk about how technological progress, like the introduction of robotics, has simplified the process of sampling tumor tissue, making it more time-efficient and supposedly less invasive. Yet, despite these advances, biopsy-related hemorrhage, or BBH, remains our primary concern.
Exactly. And what's interesting is that the need for these biopsies is actually increasing. The 2021 WHO classification of brain tumors, which incorporates more molecular and morphological features, has boosted the demand for high-quality tissue samples. So while we are doing more of these, we are still grappling with a risk of asymptomatic hemorrhage that ranges anywhere from 8% to 60%, and symptomatic hemorrhage in about 1% to 10% of cases.
Those are wide ranges, which tells me the literature has been somewhat inconclusive. We've seen studies pointing to surgeon experience, trajectory planning, patient age, or comorbidities like hypertension and low platelet counts. But this paper, coming out of the University of Tübingen, tries to settle some of that by using a very specific methodology, Voxel-based lesion symptom mapping, or VLSM.
Right. They analyzed 450 consecutive patients who underwent either frame-based or robot-assisted brain biopsy between 2009 and 2021. For the residents listening, the frame-based system used was the CRW, and the robot was the ROSA-1. What makes this study stand out is how they handled the imaging. They registered preoperative MRIs and postoperative CTs, then normalized them to a standard MNI space.
That's the key. By normalizing to MNI space, they could perform a rater-independent inter-subject statistical analysis. It allows them to pinpoint the exact spatial profile of where these hemorrhages occur and relate that directly to the functional outcome. It moves us past simple deep-seated or low-bar labels and into actual voxel-level data.
Let's look at the baseline numbers first. Out of those 450 biopsies, they found radiographic evidence of hemorrhage in 80 cases. That's 18%. The mean volume was quite small, only 1.9 milliliters.
But as we know in neurosurgery, volume isn't everything. Location is. How many were actually symptomatic?
Only 19 out of the 450, so about 4%. The clinical presentation was mostly sensory motor deficits, about 3% of the total cohort, and reduced vigilance in 1% of cases. Ultimately, 2% required surgical evacuation of the hemorrhage, and another 2% suffered from persistent neurological deficits.
That 4% symptomatic rate aligns with the historical data, but the value here is in the predictors. The authors performed a binary logistic regression. Ilara, what were the non-spatial predictors they identified?
High-grade glioma, or HGG, was a major one. This makes sense given their high vascularity. They also identified patient age as a significant predictor, but the real deep dive of the paper is the target location and the trajectory.
Let's talk about that VLSM analysis. This is where they used the software to see which voxels were most associated with hemorrhage. What did they find regarding the where?
The VLSM determined that frontal trajectories targeting deep-seated lesions in the basal ganglia were significantly associated with a higher risk of BBH. Specifically, the posterior aspect of the basal ganglia, the insula, and the internal capsule, the capsula interna, emerged as significant predictors for neurological deterioration after surgery.
That's a critical point for residents planning their trajectories. We've always known the basal ganglia are highly vascularized, but seeing it mapped out this way confirms why those targets are so high risk. The study mentions that BBH in these eloquent areas has a much higher rate of producing a permanent deficit.
And the VLSM specifically linked those basal ganglia targets to symptomatic BBH with somatosensory deficits. If you're passing through or targeting near the internal capsule, even a 1.9 milliliter bleed, which sounds tiny, can be devastating.
Did they find any difference between the frame-based and the robotic-assisted groups in terms of hemorrhage risk?
No, the study found no significant difference in BBH rates between the frame-based CRW and the robot-assisted ROSA biopsies. It suggests that while the tool might change the workflow or the speed, the underlying risk is more about the patient's pathology, like the high-grade glioma, and the spatial anatomy of the trajectory.
I think it's also worth mentioning their standard operating procedure, or SOP. They followed general stereotactic principles, avoiding sulci, avoiding transventricular trajectories, and minimizing the violation of eloquent areas. Even when following these gold standards of planning, they still saw that 18% radiographic hemorrhage rate.
It highlights that vascularity along the stereotactic corridor is the main culprit. They even noted that intratumoral susceptibility, which we see on SWI or susceptibility-weighted imaging, indicates a higher risk.
So if we're summarizing the why behind the bleeds, it's HGG pathology, older age, and that specific spatial corridor involving the basal ganglia.
Exactly. The paper concludes that while asymptomatic hemorrhages are actually quite common after brain biopsies, true neurological deterioration is rare, but when it happens, it's highly predictable based on the spatial distribution.
For the practicing surgeons listening, how should this change our approach?
The authors suggest that the role of biopsy location has been underestimated in the literature. When we plan a frontal trajectory to a deep lesion, we need to be hyper-aware of the voxels we are traversing, especially near the insula and the posterior basal ganglia. The VLSM data provides a regional specificity that older studies just couldn't achieve.
It's a call for more meticulous trajectory planning. If we know that certain voxels are high risk for causing a sensory motor deficit if they bleed, we might reconsider the entry point or the target if the diagnostic yield can be maintained elsewhere.
And it's a reminder that even though we have these advanced robotic systems, they don't eliminate the biological risks inherent in brain tissue, especially in highly vascularized tumors like HGG.
This was an excellent breakdown, Alara. The takeaway is clear. BBH risk is a combination of spatial and non-spatial factors. Age and pathology matter, but your trajectory through the basal ganglia might matter most for the patient's functional outcome.
That's all the time we have for today. We hope this helps you in your next stereotactic planning session.
Thank you for listening to the Neurosurgery Hub podcast. We'll see you next time.